I'm Matt Roberson. I'm one of the orthopedic doctors here, and first of all, thank you all for taking your time to come hear what I have to say, I guess. I've been asked to talk about arthritis, and a lot of the talk is going to be about arthritis surgery, but not all of it. I think that's something I want to say straight away, is that, I think some people in their mind think that if you have arthritis in your knee or in your hip or anything that you sort of automatically are going to need an operation, and thankfully that's not true. So all of the conversations that we have today about surgery only apply if everything non-surgical that we've tried doesn't work for you. And that's kind of reassuring. And I think it's important because occasionally I'll have people come to see me who've already made up their mind they need a knee replacement. And they're a little disappointed when I say that we're going to try something else. But surgery, I'm a surgeon. I love to operate. I think it's great. But surgery is such a big deal that to enter into surgery as a patient, you need to have the peace of mind that you've tried everything else. You need to know that you've exhausted other options, because if an injection or if a medicine or if therapy or something could make you feel better, it would be a shame to have surgery. So that's important to sort of specify. Because I am a surgeon, I'm gonna bias this a little bit towards surgery, but surgery is just if everything else didn't work, okay? And that's important. Now, first of all, arthritis, usually when we talk about arthritis, we're talking about osteoarthritis. Statistically, that's what affects most people. And I tell people all the time in the office that osteoarthritis, rather than being a disease that really attacks you, and attacks your tissues like some diseases, it's more like tire wear on a car. Now, if you drive your car far enough, the tread on the tires is going to wear down, right? And so osteoarthritis is just kind of wear and tear on the cartilage of your joints. It's an interesting thing, because I've had people sent to me because their family doctor took an x-ray and they had arthritis, so they get sent to me for their arthritis, but when I talk to them, they don't really hurt. So if you've got arthritis and you don't hurt, then that's a blessing. That's fantastic. That's the best kind of arthritis. And then I've seen people with a little bit of arthritis who really, really hurt a lot. So how much arthritis you have on an x-ray doesn't really tell us everything that we need to know about treating your arthritis. We treat based on how you feel, not based on what your x-ray looks like. The two main kinds of arthritis that I deal with the most are arthritis of the knee and hip. And because we are going to be talking about surgery some, those are probably the two biggest kinds of joint replacements that are done. There are some other kinds of joint replacements. You can do an ankle replacement, you can do a shoulder replacement, you can even do a wrist replacement, and all those things have their place, but I'm not really going to talk about that today, because I think the amount of people that would apply to would be really small. I assume by all of you being here that either you or somebody that you care about has arthritis. Is that pretty reasonable? Is that true? Right. So just by a show of hands, how many people have knee arthritis? Okay, probably about half or better. How many people have hip arthritis? Okay. And that's about what I would expect. Usually I see fewer people coming to me with hip arthritis than knee arthritis. And because of that, we end up doing surgery more for knee arthritis than we do hip arthritis. So for arthritis in general, the things that we do that aren't surgery are things that are easy, like Tylenol. A lot of people think Tylenol doesn't really do anything because it's over the counter, so it must not be that good, right? But Tylenol, if you take it 3 times a day, every day, makes some people feel dramatically better. And I've had people, I see some familiar faces in the crowd. Some of you have probably heard some of this before. But I've had people who come to me, again, convinced they're going to need a joint replacement, and I put them on Tylenol that they take routinely. They take it 3 times a day, every day, and they feel better. They don't have any pain anymore, or they have an amount of pain that they can put up with. Again, that's great. That's a blessing. That's the best possible thing that could happen. Another thing is anti-inflammatory medicine. I think we used to prescribe anti-inflammatory medicine for long periods of time, more than we do now. There's some evidence to show that there's cardiovascular risk or heart risk with taking anti-inflammatories for too long. So now basically what we do is try to treat you with the lowest dose of anti-inflammatory we can for the shortest period of time we can. And some people end up on an anti-inflammatory for a long time, but it's a decision that would be made between me and you as a patient and probably your primary care doctor. So Tylenol and anti-inflammatory medicine are two big things. And by anti-inflammatory medicine, I'm talking about things like Advil, Aleve, Celebrex. I use a medicine called Mobic a lot, medicine called Voltaren or diclofenac. And usually it's in a pill form, but in the last several years we've also gotten some kinds of anti-inflammatory medicine that are really what we call topical. You just rub them on your skin. Not great for hip arthritis because your hip is so far down there it's hard for it to really get to where it needs to do its job, but it's quite good for knees. And we have some people that just can't take anti-inflammatories by mouth because they've got bleeding problems like in their stomach, or they maybe have some kidney disease or maybe some heart disease and their doctor doesn't want them to take it. So we can give them these anti-inflammatories they rub on their knees, and a lot of people feel a lot better. So those are two big things that are really easy to do. The next thing that I usually talk to people about is injections. We can do steroid injections, and we do those quite a lot. If you hear of someone who's had a cortisone shot in their knee, it's again just a powerful anti-inflammatory that we inject right to where your problem is. This is something we do for knees. We don't really do it for hips to speak of, just again because the hip is so deep down in there it's hard to get to. And some people with maybe one or maybe two steroid injections a year can get by for a long time with an arthritic knee. The other kind of injections we do are what the doctor term for them is viscosupplementation, which sounds really fancy. But if you know anybody, or if any of you have had what's called rooster comb injections, you hear people call them that. It's usually one shot a week for about 3 weeks or anywhere up to 5 weeks. And really the best analogy for that is it's like a WD-40 injection for your knee. It's not really WD-40, but it's a lubricant. And we put it in your knee, and some people market that injection as if it's going to magically take away your arthritis. And that's just not true. What it's going to do is make a knee that has arthritis hurt less for some people, for most people. It's not a permanent fix. It usually lasts about 6 months, but we've had really good results with that. Occasionally those are done under x-ray guidance, where somebody uses an x-ray to make sure that the needle is inside of your knee. I actually kind of think that's overkill. I don't do that because, just to be honest, if I can't get a needle into your knee, I probably don't have a whole lot of business doing knee surgery, right? Because I have to get a lot bigger things than that into people's knees to do surgery. So the viscosupplementation injections are things like Synvisc or Suparts, which is the brand that I use. And again, that helps a lot of people quite a bit. And so if we try those and those things don't work, then the next step for most people is that we start talking about surgery. Is there anybody here who's already had maybe a hip replacement or a knee replacement? Yeah? Okay. That's a big surgery. It is. It's a great surgery. Most people I know that have had that would say, man, I wish I would have done it 5 years ago, or I wouldn't take this for the world. But not everybody, because it's surgery, right? Surgery has risks. If anybody ever promises you that you're going to do well after a surgery, you should run away, because they don't know anything about surgery. Because surgery has risks. And everybody knows somebody who has had something done, some kind of surgery, a joint replacement or whatever, and it didn't do as well as they had hoped, right? But for most people, a hip or knee replacement is a great option. I've got some models to show you. I actually had a really nice PowerPoint presentation with pretty pictures and all that stuff, but I don't know if y'all ever heard the, I don't know how many of y'all are Bible people. I don't know if you've ever heard the verse that all things work together for the good of those that love the Lord. So apparently for those of us that love the Lord, it was not going to be good for me to have a PowerPoint presentation because it was great. It was really nice. It was pretty slick. I think you would have been impressed. but I turned on my computer and it died. Like I can't even get the light to come on when I push the button anymore. So there's a great talk out there. We just don't have it today. But when we talk about joint replacement, we're usually, again, talking about hip and knee replacement. And I think that it's easy as a surgeon, because I think about this all the time, and I deal with this all the time, it's easy for me to kind of think that people know what that means, because it's such a familiar concept. But in a lot of people's minds, with a knee replacement, for instance, you're thinking that I'm going in and putting a hinge in your knee, right? I'm putting a new hinge in there. Really what this is a resurfacing operation. You know, the knee is the end of your thigh bone. This is a cool looking artificial knee. The knee is the end of your thigh bone and the top of your shin bone. And with arthritis, what happens is that the cartilage on the end of these two bones is worn out. And that's where pain comes from. So with a knee replacement, literally what we're doing is resurfacing that. So we have a great way, I won't bore you with the details, we have a great way of going in and taking out the very edge of the bone and the cartilage on top of that bone, making very precise cuts. They look like they were made by a machine. And then we replace that bone that we take out with metal and plastic. There's a little metal piece that fits in here, right? This plastic inserts into it. And then there's a metal piece that goes on the end of the thigh bone. So literally what we're doing is we're leaving 3 out of the 4 ligaments. When I do a knee replacement, I leave 3 out of the 4 ligaments in your knee untouched. I don't do anything to them. They're still there doing their job. And we're just resurfacing the ends of the bone. And so we're not really replacing a hinge, we're just resurfacing the ends. Another thing that we deal with a lot with joint replacements, particularly talking about knee replacements, is that a lot of people have deformities, right? A lot of people with arthritis are bow-legged, like Cliff Colley, any of y'all know him, or knock-kneed, and that either happened as their knees wore out, or their knees wore out because they were out of line, right? Again, to use our tire analogy that I used before, you know, if your tires are out of line on your car, they're going to wear out faster, right? We all know that. Well, the same is true of your knees. If your knee is out of line, one side of it's going to wear out a lot faster, and that's going to lead to having pain and arthritis and possibly even to a knee replacement. So when we do a knee replacement, if you start out with a bowed leg that's like this, when we do the knee replacement, we straighten it out and get it so that it's lined up properly. And I've actually done knee replacements on somebody where if I do 2 knee replacements on them, they're real bow-legged, they get taller, you know, because they're so bow-legged, you straighten all that out and they get some height back. I don't know if they have to buy new pants or how that works, but correcting that is important. It's important for your knee working properly, and it's important for it just holding up over time. In our history from watching these for a long time, not just myself personally, because thankfully I have other people's experience to draw from, is that the closer you get these to the optimum alignment, the better they hold up over time. And so historically, for a well-done knee replacement without any kind of complications, we say there's about a 15 to 20 year survivorship for that, which is good. Because again, historically, most people who've had joint replacements are usually in their 60s or 70s. That's the biggest group of people. And so if you can get somebody 15 or 20 years, then hopefully at the worst you may have to redo that one time. For a lot of people, it'll last them the rest of their life, which is really what the goal is. You know, we want to do one operation that's going to be a knee for the rest of your life, or a hip. And for younger people, well, I'll back up. The 2 biggest groups that are growing in terms of having more joint replacements done are people in their 50s and people in their 80s. And I think it's because we've got some people in their 50s that have been more active and have maybe worn out their knees faster. We've got some people in their 50s who have biscuit poisoning and they're carrying too much weight and they wore out their knees because of that. And so they just need it sooner, right? So we've got those people. And then some people in their 80s because people are living longer, right? Historically, people in their 80s, a lot of them just couldn't have surgery. They were too sick. But now we've got a lot of really healthy 80-something-year-old people out there, and that's great. Again, that's a blessing. That's fantastic. So, so those are the 2 groups that are growing really at a rapid rate in terms of how many joint replacements they have. For the really young people that have to have a joint replacement, We have a new bearing surface. It's made by one company. It's actually the brand of implants I use, which is called Smith & Nephew Orthopedics. And they have a material called oxinium. It's kind of a brand name. It's actually, you've heard of like cubic zirconia as a fake diamond. This is an oxidized zirconium. It looks like black shiny metal, but it's kind of a ceramicized metal, a metal that acts like a ceramic that acts like a metal. I'm not really sure which it is. But it holds up so much better than what we've used historically, that whereas in the past we've said, wow, 15, 20 years for a knee is really good, with this we can actually get 30 years out of a knee in wear simulators. This hasn't been around 30 years, but we have these machines we can put it in, and basically we put it in something like this and it gets mashed on and moved back and forth a lot of times, and we can simulate 10 or 20 or 30 years worth of wear. When they put this type of material into a wear simulator, they turned off the machine at 30 years worth of wear, and it didn't wear out yet. So that's fantastic, and that's really exciting. And hopefully that technology is going to spread out to, to other applications to just make these things last longer and make us be better at replacing joints. So anyway, this is a great model of a knee replacement. Does anybody have any questions about that? No? Okay. With knee replacements, there's obviously more than one way to skin a cat, and knee replacements are no exception. There are two big variations in the way you do knee replacements. One of them has to do with whether or not you cut a certain ligament or not, and the other one has to do with whether or not you resurface the back of the kneecap. Okay? So if any of you are thinking about having a knee replacement, that's a great question to ask. The ligament is called a PCL, whether or not you're going to cut the PCL and replace it, or if you're just going to leave the PCL there. And the other one is whether or not you're going to resurface the back of the kneecap. So I'll talk to you a little bit about hips as well. Did you have a question? Actually, when you do a joint replacement, you completely remove the meniscus. So the meniscus is kind of a C-shaped, horseshoe-shaped cartilage pad that fits. There's one on this side of your knee and one on this side of your knee. And so a lot of times in knees with arthritis, those are torn. Because if you've got so much wear that you've worn out this side and you've worn out this side, you probably wore out what was in the middle too. Not all the time, but a lot of the time. So yeah, we completely cut those out because they just don't have a job to do in a replaced knee. Actually, probably about 5 or 6 years ago, I had a patient who had a knee replacement done, not by me, and he overall was doing really well, but occasionally he would just get this sharp stabbing pain in his knee. And he said, it's kind of like some of the pain I had before I had my knee replacement. It's just weird. So I tried a bunch of other stuff and he didn't get better. So eventually I said, well, we'll scope your knee, right? So a very non-invasive surgery, going through 2 little tiny incisions. I went in and scoped his knee, and the person that had done his knee replacement didn't take out his meniscus. So he had a replaced knee, but he still had the meniscus tissue in there, which I've never seen any time ever other than that. So I took out his meniscus, and he magically felt 100% better. So even if we were to leave the meniscus in there, it would probably cause problems. The situation you talk about, though, where if somebody has a torn meniscus and they have arthritis, is something we deal with a lot. Because a lot of times somebody will come to me from a family doctor and they've had an MRI. And the MRI shows that they have a torn meniscus. And so they come in, and typically if you just have a torn meniscus, we would do a knee scope, which is a very easy outpatient surgery. In somebody with arthritis, we have to be very careful, because if you have arthritis and a torn meniscus, if we're not very careful about what we do, if I just schedule you for a scope and I go in and trim out the torn meniscus, then you're still going to hurt, and some people will actually hurt worse after that. So very seldom do I do arthroscopy or scoping on knees that have torn cartilage, if they also have arthritis. Did you have a question also?
What material is replacement?
Well, when we do a knee replacement, we don't replace the meniscus. You leave it out completely. What the knee replacement is there are 3 main components in the main part of the knee. There's this cap that goes on the end of the thigh bone, the end of the femur, okay? And that's made out of metal, okay, either the traditional metal or that newer metal that I mentioned. this is actually two pieces. There's what's called the tibial component. These are models. These aren't actual implants, so they're a little bit more difficult to work with. I'm going to leave that in. There's the gray piece here, which is metal, which goes down into the shin bone, and then this plastic piece fits into that. Okay, so those fit in like that, and these things fit together so that we don't actually replace the meniscus. There is a technology for young healthy knees that have a really badly torn meniscus to go in and transplant a meniscus, but that technology is in its infancy really. It's not something that's broadly used, and for somebody that had arthritis would be completely the wrong thing.
So someone with a torn meniscus.
Yes, ma'am. If somebody has arthritis and a torn meniscus, then if when they walk around they occasionally have a sharp stabbing pain that gets them all at once, makes their knee feel like it's going to lock up or catch, but the rest of the time they feel okay, then that person I would consider doing an arthroscopy and taking out the torn meniscus. We don't replace it, we just take out the torn part. If that same person with the same meniscal tear and the same arthritis said, yeah, my knee hurts, it's worse at the end of the day, it's worse when I've been on my feet a lot, if I'm really active I know I'm going to pay for it later, I'm stiff if I sit down for a while. If I did an arthroscopy on that person to fix their torn cartilage, their knee would probably hurt worse afterwards. So that's where the responsibility is on me to make sure that I'm doing the right thing for the right person. Yes, sir. That's a great question. It probably takes me in the neighborhood of an hour and a half. Actually, Jennifer, this is Jennifer Brooks with the fancy hat on. She works in the operating room. About an hour and a half usually for my knees. Yeah. And I would say that that's different for different surgeons. Among the orthopedic surgeons here, some of us take longer, some of us take less. And I know guys that really get excited because they can do a knee replacement in 45 minutes. Yeah, right. Well, if he did both of them in 45 minutes, he was moving. Oh, each, okay. And I would say, I know, there's one guy I'm thinking of in general, I know a guy who does a 45-minute knee replacement that I wouldn't mind my mom having, right? I also know some guys who do 45-minute knee replacements that I would not want my mom to have. Yeah, I know Dr. Jennings, yeah, and I think he does good surgery. But my point is, some people do it in 45 minutes, some people do it in 3 hours. And whether it's 45 minutes or 3 hours, the important thing is that when he sews up the skin and walks out of the room, that you've got a great knee. That's what's important. And I strive to do the best knee replacement that I can do. And if that takes me 45 minutes and I feel good about it, then that's great. And I actually have done a couple that fast. But sometimes it takes me 3 hours because something's really hard about it. And the responsibility, again, that we have when we're in the operating room with somebody is that we don't leave until it's a great knee. And that's what's important. Yeah, there you go. Yeah. Perfect. And you can't eat before surgery, so you don't have anything else to do on your lunch hour. Yeah, we do actually. We would go in, and this is just the replaced parts, but we would go in, we would first of all make an incision in the front of your knee, okay? And actually, let's see, yeah, this is the left knee. So in the front of your knee, and then we would take your kneecap and either scoot it over to the side like this, or believe it or not, sometimes we flip it over like that because it gets out of the way. And then we have a thing that goes up inside the femur, so that we can assess the alignment, because obviously the way we make these cuts is really important so that you don't have a crooked knee, right? So we have something that goes up in there and allows us to see how big your femur is, right? Because these are like shoes, they come in different sizes. If I put the same knee in somebody my size that I did in somebody, a little bitty woman size, then that wouldn't work for everybody, right? They're not one size fits all. So we measure how big this is. And then we make several cuts that, I don't know how we can see that, but if you see the end of this, they're very precise cuts on the end of this. Again, they look like they're they're made by a machine. They're incredibly precise, okay? And those are made to accommodate these, which come separately, and they're sized and they're sighted, and they're very, very specific to what we do, okay? Then we do a similar thing with the top of the shin bone, okay, or the tibia. We cut it off, and it's as flat. When we do it, the cut is literally as flat as that looks. And then we have some what are called trial implants, okay, which they're not the permanent ones that are going to be in there, but they allow us to put implants in there and make sure we like the way everything feels. We usually, at least when I do it, I resurface the kneecap, so we cut off the back side of your kneecap. And I don't know if you can see this little plastic thing that's on there. You put something on that looks exactly like that. And then we put the trial implants in and make sure that your knee comes out all the way straight, and that it bends all the way, and that we like the way it aligns, and that the ligaments feel stable, and make sure your kneecap aligns appropriately. And then we put the permanent pieces in. So we put the permanent pieces back in. All this is very precise, and it's very well instrumented so that we know exactly what we're doing and exactly how we're putting it in, and that we're putting it in appropriately. And so then when we do that, again, we have this resurfaced knee. And then we wash everything up. A lot of times we'll have a drain that would drain any bleeding that happened in the knee after surgery. I put a great big ginormous bulky dressing on there afterwards. And then most people would be in the hospital for about 3 days after the surgery. And there are a lot of extra little steps in there, but that's pretty simply how we do this operation. And again, it's a great operation. And everybody responds differently. A lot of times people ask me, well, how long is it going to take me to get over this? And the first question is, well, how do you define over it? How do you define it? Do you mean as good as you're going to get? If you mean as good as you're going to get, it's going to take you about a year to get as good as you're going to get. But if you mean hurting less than you do now, that may be really quick. I've done a couple of these. There's one guy in particular I remember where I went to check on him, after his surgery, the same day. He was sitting on the edge of his bed, sitting up, swinging his legs like this, back and forth. And I almost passed out. I couldn't believe he could do that. Another gentleman, it was either the day of surgery or the next day, when I walked in the room, he was standing up next to his bed, with his gown on, and it was unfortunate the back of the gown was open. It was kind of a bad scene. But he still had his IV in, and he still had his drain in his knee. But he was standing up, and he said, "I thought you said this was going to hurt." And again, I almost passed out. So some people just do amazingly well. Most people don't do as well as those two guys. That's exceptional. And it's just because different people respond to surgery differently, and different people experience pain differently. But pretty reliably, within several weeks after surgery, people have less pain than they did before. And generally what people say is, the pain I had before is gone. The pain I have now is sore. I can tell that you did something to me. Because this is very elegant surgery in terms of how we do it, and it's very precise, but it's still surgery. It's still saws and hammers, It's a big deal. And if you typically would have an incision that's, probably from about here to here, and I wish I was good enough to be able to cut a hole in the front of somebody's knee and not make them hurt, but I'm not that good. I don't know anybody who is. So we do a lot of things after surgery to make that as comfortable as it can be, and most of my patients never take any IV pain medicine. They're only on pills for pain after surgery, and they do amazingly well. And then after surgery, so 3 days after surgery, people leave the hospital. They either go, depending upon their health and how well they're getting around and how much support they have at home, they would either go home and have home health physical therapy come out and see them for a while, or they may go to a rehab facility. And just, those are people who aren't quite ready to do things on their own, or to do things with a family member assisting, but they're just not bad enough to be in the hospital anymore. So that's kind of an in-between point. And then after that point of time, you would go see the good people at physical therapy. These are two representatives from Praxis Physical Therapy, and work there. How long would you say? Probably 3-4 months usually after a total. Yeah. And see them initially about 3 days a week, step it down to 2 days a week. You'd have some home exercises to do on your own during that time. And I generally tell people that it's a year after surgery before you feel as good as you're going to feel. But it's usually pretty quickly after surgery that you can tell that the pain you had before is gone. And that's encouraging. Do y'all have anything else to add to, with the therapy piece for knees? That's a great question. My first response to that is the reason to do this surgery is this is a pain relieving surgery, right? Now, another benefit of it is that you tend to get better motion, right? Usually knees that have a lot of arthritis are fairly stiff. Not all of them, but a lot of them are fairly stiff. And so when we do the surgery, we do everything we can to make them move as well as possible. And so when I have somebody on the operating room table, I would tell you their knee will straighten all the way out and their knee will bend probably at least that far on the operating room table. The problem is after that, they wake up and then they can feel pain. And so soreness sometimes keeps people from moving quite as well afterwards. And you really have to work to get that back. Typically what I tell people is it's the patient's job to get it out all the way straight. And there's some instructions we give you for that. It's physical therapy's job to make it bend. And so I would usually say 120 is probably a good goal. The best predictor in my mind of how well somebody's knee is going to move after surgery is how well it moves before surgery. I've had some knees that are amazingly stiff before surgery. And again, during surgery, I get them so they can move great. But all of the soft tissues around the knee kind of remember that, and they kind of want to gravitate back towards that. I even think that your brain over time learns what range of motion your knee is going to go through. And even after we fix your knee, your brain still thinks that's as far as it can go. There's probably good science behind that, but I can't really tell you what it is. So your people just don't move as far past that because your brain sort of tries to stop you before you get there. So people with really stiff knees beforehand have to struggle a lot more to get their knee range of motion back afterwards. People who have great knee range of motion beforehand tend to have a great knee range of motion afterwards. The other thing that sometimes I've seen is that if somebody has a really big leg, we get what's called thigh-calf impingement, where if we just measure the number, we might look and say, wow, she can only bend her knee, about 95 degrees, which is about like that. And you think, man, I wish she could get more motion. But if you actually look closely at somebody's knee, when they do that, the reason that it only bends 95 degrees is because when they bend it that far, the back of their thigh and the back of their calf are touching, and they just can't go anymore. Something's got to give. So I think that's a limiting factor. And I try to tell people that if I think they may, try to tell people that delicately if I think they may fall into that category. So yeah, about 120 degrees. So, and I think you had a question, sir? If we look, and it's not on this model because this model is a replaced knee, but your ACL is kind of in the middle of your knee here, okay? Your PCL, the C in ACL and PCL stands for cruciate. So cruciate means, cross-like. Your ACL and PCL cross kind of in the middle of your knee right here. The PCL is in the back. And so in every total knee replacement that's done, the ACL gets cut. And the way these things fit together and stabilize each other substitutes for that. The PCL in the back gets cut. Yeah, I told you one of the things is whether or not you cut a certain ligament. So probably 50% of people cut the PCL when they do that, and then they have an implant that has a big post right here that does the job of the PCL. And then the other 50% of us don't cut the PCL. I actually don't cut the PCL. And if you look at, there's tons of research for all this stuff. If you look at the research, usually what you find is that whatever a surgeon likes to do the most, when he does his research, it shows his way is better. So the people that like to cut the PCL do research that shows that cutting the PCL is better. The people that like to retain the PCL do research that shows that retaining the PCL is better. And probably they're both great. If you have a complete tear of your ACL, then it's not going to heal. And the reason for that is because it's bathed in joint fluid, and the joint fluid keeps things from healing together well without getting really scientific about it. And so it won't heal together. If you tear it a little bit or maybe stretch it, then it may sort of heal back enough to have good stability. Some people, especially in an arthritis population, there are people walking around with torn ACLs that probably do fine because their knee is stable without it. What's that? Right. You just don't get in the positions to do that. My father-in-law is 62, I think. He's a very fit, healthy 62, but he tore his ACL when he was in high school. And when he was in high school, we were terrible at fixing ACLs, so we didn't fix them very much. We're actually really good at it now. But he never got his ACL fixed, and he's fine most of the time. But if he plays golf or does something where he gets in a certain position and rotates correctly, his knee will give out. So, but we always cut the ACL when we do knee replacement surgery. There's a new effort to try to do a knee replacement that saves the ACL and the PCL, but really, again, it's in its infancy, and it's not really in broad usage yet. And I think it remains to be seen whether or not that's going to be something that's going to be beneficial or not. So, anybody else have any questions? Sometimes when somebody responds like that, I think there's a significant component of anxiety, because anxiety and pain are really closely linked, and I know y'all probably see that a lot. Something that we have that I think is a huge asset is that, I'll say this, if they said it, it would be bragging, our physical therapists are great. And so one part of getting somebody past that is you got to trust the person that's moving your knee, right? And so, yeah, exactly. So when somebody hollers before you touch them, that means she's probably tough too. The other guys were probably men. Men, they were fussing. So as much as I hate to admit it, women are tougher than us. So it's hard to say that. And Andrew, I have no idea where I am on time, or so just tell me if I need to. What's that? 10 more minutes? Okay. If anybody else has any more questions about knees, I want to address them, but I wanted to talk a little bit about hips too. So with hip replacements, the two main reasons to do hip replacements are osteoarthritis, okay, so the same thing that we talked about before in terms of just being tire wear. And then some people have a thing called a vascular necrosis, where the ball joint of your hip loses its blood supply and it actually dies and collapses. Okay, so either one of those things can make somebody need a hip replacement. Like I said, for the knees, you can have a little bit of arthritis and hurt a lot, or you can have a lot of arthritis and not hurt very badly. And the only reason to think about having a hip replacement is for pain relief. A lot of the things that are options for knees, like the injections and the topical medicines we rub on the skin, don't work well for hips, because hips are just under so much other stuff. They're hard to get to. But with hip replacements, what we do, I don't like this model as much, but I'm going to pick it up. It's actually way easier to deal with a normal hip in a person than it is to deal with this model. So with a hip joint, this is kind of half of your pelvis, okay? This is your hip socket. When you do a hip replacement, you go in with a thing that kind of looks like a cheese grater, except it's round, and it grinds out all the cartilage and the bone from inside of this. And then you've got a metal piece we call a shell, that gets hammered into there, and it gets hammered in so tightly that it won't move. It actually attaches to your bone, and eventually your bone grows into that. Then we put a plastic piece in there. It's a similar plastic to what we use in the knees. Calling it plastic is probably not fair to it. It's actually called polyethylene, or ultra high molecular weight polyethylene. And it's like the coolest plastic ever. It lasts a long time and is amazingly strong. So we put that in, and then with your thigh bone, we actually cut off the ball joint of your femur or your thigh, and we put this thing down into the femur. Okay? It again fits very tightly in there. Most of the time with a hip replacement, we don't use orthopedic cement, which we use for some other things. We just hammer it down into there, and it stays in a very tight way. And then this ball goes into this socket, and you've got a new ball and socket joint. Hip replacements, and again, I'll see what you have to say about this, Rhonda. Hip replacements seem to be a little bit easier recovery to me than knee replacements. And with hip replacements, we don't really have to focus so much on motion. Really what we're focusing on is just getting you mobile, getting you so that you can walk, because your hip doesn't have to move nearly as much for you to get around well as your knee does, right? The unique thing about hip replacements is that there are certain positions after a hip replacement that you should avoid kind of forever, okay? Because with a hip replacement, we strive to give you a very stable hip, because what we don't want to do is have your hip pop out of joint. If you have a dislocated hip after you've had a hip replacement, that's a big deal. That's not sort of a pop it back in yourself thing. That's like a go to the emergency room and probably have to go to the operating room kind of thing. It's a big deal. And so there are certain positions you have to avoid. When I do a hip replacement, I try to give you a hip that's so stable that you'd have to be trying to pop it out, okay? Because nothing personal, but I don't trust you. I don't want you to pop your hip out. I want to make it very, very hard to pop your hip out. So, but still, there are certain positions you have to avoid. The therapists actually do a lot of the teaching of what those positions are and how to avoid it and how to be careful. But people with a hip replacement a lot of times will come in 2 weeks after their surgery to get their staples out, and usually are already amazingly pleased with how well they're doing. And do you have anything to add to that? Yeah. I'm sorry, go ahead. You start to say something else? Okay. The other thing that's unique about hip replacements that I'll tell you is that something that I always talk to people about, and if you're thinking about a hip replacement, you should make sure to talk to your doctor about, is your leg lengths. Okay, obviously, I'm cutting off the ball that's there, I'm putting something new in, it's a replacement part, and you can change somebody's leg length. And so what we have to make sure of is that you have a stable hip. So if you have a hip that's makes your leg exactly the same length, but it dislocates, then nobody's done you any favors. We have to make sure you have a stable hip, and occasionally that means you may have some difference in your leg lengths. Actually, the most common reason for orthopedic surgeons getting sued for malpractice after a hip replacement is leg length inequality. Okay, so the leg's not feeling like they're the same length. If you talk to somebody about that beforehand, people know that it may be an issue, and they're fine with it. If you don't tell people that beforehand, they feel like they've kind of been misled, and they feel like you messed something up. I would say most of our patients are so close on leg length that they don't really perceive it, and even if somebody perceives a little bit of a difference, they aren't bothered by it. I can think of one lady off the top of my head that I've had to give a significant heel lift to, and what we would do is if your surgery leg feels longer, we would give you a lift that goes in your shoe on the other side. If your surgery leg feels shorter, we give you a lift on the heel of your surgery leg, and people do great with that. But again, and I can't swear that I'm being 100% correct, but I can only think of one person I've had to give a heel lift to that I can think of. So, yeah. But hip replacements are great. They do well. You can usually put weight on them the day after surgery, just like a knee. And again, our patients typically do well. My patients in the hospital usually don't have to take any IV pain medicine after the recovery room. They usually just take pills for pain. And with the hips and the knees, we do a lot of things in addition to just narcotic pain medicine that decrease how much medicine you have to have. Because if we give you a lot of medicine, then you're kind of goofy-headed, and you get constipated, and you're nauseated, and you feel bad, and you're sleepy, and you can't work hard with therapy. So we do a lot of other things that are non-narcotic that decrease how much pain medicine you have to take. We've had great results with that. I actually went to a meeting in New York City over Christmas that's done by a hospital called the Hospital for Special Surgery that's in Manhattan. It's a great orthopedic hospital. They do great work. And it was all about knees. We didn't talk about hips. But when I looked at what they do for pain control and anesthesia and recovering from surgery and all that stuff, at our little podunk country hospital, we do all the same things they're doing at the big fancy, state-of-the-art hospital. So I was really proud to be able to come away from that and say, I could have told them all that stuff. That was nice. That was satisfying. At this time, I think I'm almost out of time, but I'm going to open it up for any other questions. And I also wanted to take time to introduce some of the people who have left, but we have Joyce and Katrina here from our office, Upstate Bone and Joint. I would say that however good I am at my job, they, along with the other people in our office, make me look better than I really am. It's something that you can be a great surgeon, but if you don't show people that you care about them, then you're not a great doctor, and you're not great for those people. It's important to me that the first face you see when the glass slides back when you're in my waiting room, and every face you see after that until you walk out my door shows you that we care about you getting better, and we sincerely want the best for you. And I would say that all these people in my office make that happen, and overall make people get better faster. Because if you really can tell that we care about you, and I mean, I don't want to seem cheesy, but I think this is true. If you really can tell that people care about you, you get better faster because you're on board and you're optimistic, and there's really something to that. So I promise I'll answer questions. Who's got questions? Yes, ma'am. That's a separate disease from arthritis. That usually is due to either steroids like prednisone. Okay, people have to take prednisone for other disease processes like their lungs or something like that. It can be due to heavy alcohol consumption, and not like one person who overdoes it on one weekend, but people who drink a lot for a long time. And the far less common cause is people who get the bends, people who scuba dive and go down really deep and then come up too fast and the nitrogen is released into their blood. That can cause it too. I've never seen anybody who got it from the bends, but the drinking and steroids are the two main causes. No, usually people with, we were talking about like peripheral vascular disease, like, you know, what we call atherosclerosis, those two things don't go together. No, ma'am. Yes, sir.
I want to add to something to what you were saying, back when you were up on talking to these people about caring about them. There must be 50 doctors working this hospital. This man right here is the only one. You've been a patient here, you've done outpatient surgery on you, or you're an inpatient. Before he goes to bed that night, he's going to call him home and say, how you doing? Out of all we got here, he's the only one that does that. That tells me you're a trained patient.
Thank you.
I can back that up by saying when we left your office, you said, thank you for allowing me to be your doctor.
Well, thank you. Does anybody else have any questions? Yes, ma'am. I'm sorry. It is. I think that anti-inflammatory medicine is very sort of, the doctor word for it is idiosyncratic, which sounds really fancy, but it's really specific to a given person. I know people who take naproxen and they don't hurt a bit. And if they take ibuprofen, which is Advil, it doesn't work for them at all. And I know the opposite. I know people who can take any one drug and that works better than any other drug. And I think it's because we're all just made a little bit differently. And if it's worth trying several to see which one works best for you. But if naproxen works for you, then I think it's a great drug. It's been around forever, and I think it's, you know, I think it's relatively safe. Yes, ma'am? That's a great question. The best thing you can do to prevent arthritis is to be healthy and active and thin. Okay, a lot of people that come to me, especially with premature arthritis, are very heavy. And it's been shown that every extra pound you have on over your ideal body weight makes 4 to 5 pounds difference for your knee. So, you know, we live in the biscuit belt. Everybody, you know, I went to a wedding in another country one time. A friend of mine from college was from another country, and he got married in Finland, and I went to his wedding. I was the fattest person everywhere I went in Finland. It was crazy. I'm 6'4", I weigh 210, and I was the fattest person everywhere. And everybody knew I was American. I wondered if those two went together. I don't know. But there are a lot of people that are 50 pounds overweight. Like, that's just sort of normal overweight. And so 50 pounds, even if you're conservative about the math, makes 200 pounds of extra force across your knee. And that's amazing. So I've had people that come to me that, again, are convinced they need a knee replacement. If I can really get them to lose a significant amount of weight, then they don't really hurt anymore, even though they have the same amount of arthritis. So that is very good. Also, exercises that keep the muscles around your joint strong help stabilize your joint, and help decrease the amount of pain that you have. Intuitively you would think, well, I'm hurting, so I need to just sit down and not really put it to the test. I wouldn't want you to go train for a marathon, but I would want you to walk on flat ground and exercise and be strong. Right. Absolutely. And the other thing that does is, as people age, we have to talk about fall prevention. And if you're exercising, if you're strong, your strength is better, your balance is better, your reflexes are better. That will make you less likely to fall, and all that exercise actually makes your bones stay stronger so that even if you do fall, you're less likely to break something. So I think that's great. I think that's the best thing you can do. I think I'm out of time. Andrea's walking over here.
Do you guys have any other questions?
Sure. Thank you. If anybody has to leave, thank you for your time. I think we have some business cards up here. If anybody wants to get in touch with us, and we would love to take care of you.